Yeah, so we're now going to move on, and it's my pleasure to welcome Andre Mason. So Andre is a PhD candidate and intern psychologist with the Department of Psychology at the University of Otago. His primary area of interest is in mental health and suicide, with a particular focus on developmental trajectories and the impact on mental health outcomes. Andre is presenting on how alcohol and cannabis impacts the suicidal trajectory. So kia ora and a very warm welcome to you, Andre.
Kia ora. Thanks for that introduction, Fiona. So again, my name is Andre Mason. I am currently wrapping up my PhD, which will hopefully be done soon, which will be a relief, and in the final stages of my internship within the clinical psychology department as well. And really what drew me to this topic, which I guess a lot of people look at and go, there's a high degree of emotionality, was that 4 years ago when I embarked on this, there was a lot of chatter about the issue of suicide, but even as a budding psychologist who had an interest in the area, I knew very little about it. So I wanted to understand that suicidal trajectory and beyond just the outcomes. So what was actually leading people to be thinking about killing themselves, and I guess thinking within that trajectory.
Hi, Andre. Sorry, it's the e-conferencing team here. Your microphone has just gone a bit strained on us. Would you be able to just click under the top of Zoom is the control panel. If you just maybe switch between microphones. I'm not quite sure which one you're using. If it's from.
Is that better?
Yeah, it's a lot better. Yeah, awesome.
Way
Thank
better?
you. Thank
cool.
you.
So how much of that was hearable? Or should I just restart?
If you could just please restart, that'd be lovely. Thank you.
So, yes, Andre, if you can start.
We'll just keep going. So I guess the main rationale for wanting to look at this topic in general was really to understand that trajectory. So if we think of suicide as an issue, it globally impacts or is associated with about 800,000 deaths per year. And throughout this presentation, because it does draw from an Australian data set, I will be primarily talking Australian statistics, but where possible, linking those back to a New Zealand context. So we know it's a big problem. And in 2020, it was the cause of over 3,000 deaths in Australia. And our latest data within New Zealand indicated it was associated with nearly 540 deaths. And that is a decrease from the last couple of years, but we're yet to see that long-term trend to know if that was a sign that any of our prevention frameworks are working. We also know that men are well overrepresented within our suicide statistics and more likely to die by suicide. And then if we're thinking of what the leading causes of death are, in some parts of Australia, suicide is that leading cause of death in midlife. So I guess this is just the context for how big of a problem this can really be. But then across the literature, there's an ongoing argument about what do we focus on? Do we focus on the outcomes? Are we thinking about suicidal ideation and the prevalence rates? Are we thinking about the attempts, or are we thinking about deaths? And for a long time, that's all the literature did focus on, was suicidal ideation. And it was thought that the same processes that would lead to suicidal thoughts would also catalyze and explain a suicide attempt. But in the last sort of 10, 15 years or so, there's been a greater focus on the transitions within that component, and realizing that the variables which might help to explain the emergence of suicidal attempts are distinct from those that facilitate the transition to making an attempt there. So some of the model lists have looked at really what is catalyzing that progression. And Roy O'Connor in Glasgow developed what he called the integrated motivational volitional model of suicide. And so he put forth 3 phases there. One, looking at the background of the individual, then the motivational phase. So what was leading an individual to begin thinking about suicide? And from there, a 3rd phase, that volitional phase, that was basically trying to explain what are the factors that are enabling someone to act on those thoughts. And that's really the key aspect of this presentation, is that box there relating to the volitional moderators. And in particular, given that we're talking about alcohol and cannabis, I want us to look there in those examples towards impulsivity and physical pain sensitivity, which might become more emergent in our discussion later on. But also holding in mind there the importance of access to means and fearlessness about death. So one of the big thoughts around what allows individuals to progress from thinking about suicide to acting on it is developing that capability too. So what allows them to overcome the biological instinct to survive? And so now if we start linking in the context of the alcohol and cannabis to the suicide picture, we know that alcohol precedes approximately a third of all suicide attempts, and that acute alcohol consumption increases the risk there. But we also know that alcohol is indirectly related to suicide attempts and is instead mediated by other factors, for example, substance use or depression. And so what this is pointing out to us is that alcohol seems to have more of a time-sensitive relationship and might be more related to individual not feeling great about themselves or about life, drinking, and that somehow catalyzing more of a disinhibition type effect. But we don't yet know how that's been involved within the trajectory because the research just hasn't got there yet. But then in contrast, if we talk about cannabis, we know that it's directly related to suicide attempts, which is different to alcohol. And that this relationship is more dose dependent, so more frequent users are at greater risk. So it's not necessarily related to that acuteness of the risk, but more about the frequency. And that really begs this question when we're beginning to think about drug reforms or the liberalization of drug reforms and going, how is this potentially going to increase our risk of possibly lethal attempts happening? And that led us to our research aims today. And the first one was replication there. So when we're looking at suicidal outcomes within Australian men, do alcohol and cannabis predict outcomes? And then how can we extend that and look at the transition there? So we used the Australian longitudinal study of male health, also known as the 10 to Men study. And this is a really large scale representative cohort study within Australian males aged from 10 to 55. And for the purposes of this study today, we looked at the adult data from waves 1 and 2. There has recently been a release of the wave 3 data. We just didn't have access to it for this particular presentation. And so how were alcohol, cannabis, and suicide measured? Alcohol used the audit, which is a pretty standard measure of hazardous alcohol use. Cannabis was a single item asking how many times in the past 12 months had an individual smoked or used marijuana and recorded on a Likert scale. And then suicide was asked using binary responses of yes or no to have you had thoughts about killing yourself or have you tried to kill yourself? So at the first step, we can look at the counts. And so we had a large sample of nearly 7,500 individuals involved and quite high levels of suicidal ideation and suicide attempt. And I suppose the most concerning aspect of some of these numbers is that they are consistent to what we're seeing around the world. So, and increasing over time. So in that first wave, almost 20% were reporting suicidal ideation, and that had increased to nearly 25% by the next stage. And then we're seeing 5% approximately making suicide attempts. So when we put that into a room or into the perspective of that's 5 in every 100 people saying they want to make a suicide attempt, that is rather concerning and indicating that we really do need more effective suicide prevention frameworks to support these men. And then if we look at the outcomes, and I am aware that these graphs are slightly small, but bear with me because the main point of what I'm trying to get across with these is what it's indicating. And so if we're looking consistently across both waves and ideation and attempts, we're seeing that cannabis is having a greater association towards the likelihood of these suicidal outcomes relative to alcohol. So across the 4 graphs, both relationships are significant and do indicate an increased risk of the suicidal outcome, but that association and effect is stronger for cannabis. And that's sort of an ongoing pattern that what we see, and does indicate that replication effect that we were going for in terms of seeing how Australian men associate and relate to suicidal outcomes around the world. But our next part was that extension. So how can we understand the transition between suicidal ideation and suicide attempts? And with a rather significant amount of data wrangling, we were able to code for that. So we took what the person had experienced at time 1 and had that changed or remained stable at time 2. And what we see is that most people in general remain stable across time. We would have liked to have possibly seen more movement towards that neither category, which is experiencing no suicidal ideation or having made an attempt. And instead, we see quite a significant chunk there moving towards suicidal ideation. And that's really reflecting that count-based data, moving from the 19% experiencing suicidal ideation to 25% there. But what we're really interested in is zooming in on those who were experiencing suicidal ideation and what did they do over time. And so we see approximately 20% moving towards not thinking about suicide, which is our best case scenario. But we see the majority of people continuing to think about suicide and experiencing more of a chronic suicidal ideation. And we see about 8% there moving towards making an attempt. And that's really our concern, is what is facilitating that progression and potentially creating a context where a death could occur. And so then if we look at how alcohol and cannabis are related, we see that alcohol isn't related, but cannabis is. And that's relative to those who remain stable and thinking about suicidal ideation. And if we then compare those who progressed from suicidal ideation to making an attempt relative to those who moved to not having any suicidal thoughts at all, the effect is even stronger within that comparison. And so if we're thinking about what that means, overall, cannabis but not alcohol may be facilitating that transition from suicidal ideation to suicide attempt over a period of time. And that's really the key thing within this particular data set, is looking at that time laggedness. So we know that alcohol is associated with the outcomes. We saw that it's consistent within the literature, but it didn't seem to be related within that transition. And we have to ask the question, is this due to alcohol's association with suicide being more connected to that acute consumption? So is it having more of a secondary effect, like the past research has suggested, as a mediator towards factors such as depression? So thinking about that, and I guess that's really a question we've got to keep asking. And then cannabis, what's explaining that effect? And I don't really have the answers at this stage, but it's saying, is cannabis having a more prolonged effect beyond that acute consumption? Because we do know from past research that acute cannabis use wasn't being a factor in those suicidal outcomes. But we do also know from the research that cannabis has an effect on suicide risk, both 24 hours preceding an attempt and across a month. So is there something about the psychoaffective effects of cannabis and the highs related to that, which over time is allowing people to develop a greater capability for suicide? And if we think back to that model and thinking around the factors which Rory O'Connor suggested, things like physical pain sensitivity, impulsivity, capability for death, and fearlessness about death, we've got to really consider how is alcohol and cannabis being related to that. And that's really one of the things that helps us potentially distinguish the differences between the relationships with the outcomes and the relationships with the transition, and alcohol being a disinhibitor and helping to reduce potentially some of that fear, whereas cannabis might be having a more prolonged effect to changing our thought patterns around what our life is like and whether it is worth carrying on. And so if we're reflecting on this data, the strength was that it's a really large scale representative sample. And when we think about suicidal research, it is tricky because as common as we might all know someone who has been affected by suicide, it is still a statistically rare phenomena. So we do need those large samples to understand the effects. And I guess it's really put into contrast there when we've got a 7,500 individual sample and we're still seeing about only 200 suicide attempts within that. It does make it tricky to study. And then within those limitations, as I've already kind of alluded to, it's that time-lagged nature of the longitudinal cohort. So there was about a 2-year period between the waves. And we know that suicide is nuanced when it comes to time, and that suicidal thoughts can be fleeting or chronic, but also we're not necessarily seeing large portions of time between that transition, but we can't reflect that within the sample here. So take homes is alcohol and cannabis were both associated with outcomes, but only cannabis was associated with an increased likelihood of transitioning to a suicide attempt. And if we're thinking where to from here, more research, we need to try and understand what the mechanisms are for how alcohol and cannabis are impacting suicide, but it also relates to a need for greater awareness within drug and alcohol policy, particularly as we consider greater liberalization of drug reforms. And then just to finish off, I'd like to acknowledge the Team to Men study for providing access to their data and also the Australian government funding that. And then the University of Otago, as well as all of our co-authors who are based across New Zealand and Australia. Thank you.
Kia ora, Andre. Thank you for that. That was really interesting. Now we've got a couple of questions for you in the Q&A. So they're both from Ben. So the first question was, in terms of the study, was there no attempt to use the Dunedin longitudinal study data?
So for this particular presentation, we were using the Team to Men data, and the Dunedin study data would be used in another project.
Okay, thank you for that. And then his other question was around, was there any statistics on how many men commit suicide who are removed from their children? Did you look at that as one of the factors that influenced, or maybe the impulsivity of the attempts?
No, but again, would be the struggle with that, and we didn't look specifically at that, but the struggle with that would be that time-lagged nature, and knowing that when we think about suicides and when a suicide attempt is most frequently made, it's after a sudden change in a person's life, and that's really probably what we'd be capturing within that. And yet the study doesn't necessarily allow us the nuance within that, just because the time waves were 2 years apart.
Okay, and I can see that James has got his hand up. So James, would you like to ask your question?
Yeah, hi. Thanks, Fiona. Thanks, Andre. I'm interested to know whether you've got the ability to drill down to other specific groups of men as well. I know, for example, in East Arnhem Land in the Northern Territory, there's some differences in trends. So I know in a previous AOD role that I was in that it was estimated, well, it was found that 100% of suicide cases in East Arnhem were related to alcohol, which bucks the trend that you've just spoken about. And I'm wondering the degree to which you've got that granular data to be able to look at specific population groups or geographical regions where things might look slightly different.
Yeah, that's a tricky one, just because I guess when we think about some of those more rural populations within such a large scale data set, we're just losing numbers. And that is probably a step that we'd be looking for in another study, and talking with Team to Men about how can we really develop that, knuckling down on it to understand that. And I guess it is an unfortunate thing that just the sheer sort of population level analyses that we've done looking at the general rates across Australian men do restrict us from looking at that more ruralization type effect.
Cool, thanks.
No worries.
Yeah, that was going to be something I was really interested in, Andre, being my area, being rural, and knowing that alcohol and impulsivity are really linked with access to firearms and also poisoning. So
Yeah, I guess
yeah.
it's also, if we're thinking in terms of the trajectory as a whole, and considering the factors that are more related to us moving from that piece without it necessarily being an impulsive decision. And that's really what I guess we're capturing within that, is over that 2-year long-term progression, cannabis seemed to be the bigger influence, whereas we do know that alcohol is still related to that acute risk, or intoxication is still related to that acute risk.
Okay, all right, well, thank you very much. That was a really interesting and informative talk, so thank you, Andre.
Thank
And
you.
so